Help, help, DNA. I'm your neighborhood genetic counselor, Kate Wilson, and I'm asking you to rate and recommend this podcast. This helps everyone access the show and learn more about their DNA. Feel good about sharing reliable science and getting virtual high fives from me. All right, so today I am talking to Susanna Smith, she, her, about the definition of rare disease and her experience with rare or maybe not so rare disease, CADASIL. CADASIL is an inherited condition which causes the thickening of the blood vessel walls to block the flow of blood to the brain. Susanna is the founder and host of Genetic Frontiers, a podcast about the promise, power, and perils of genetic information. As a journalist and researcher, she writes about the future of medicine, genetics, and technology in healthcare. We touch on the right not to know genetic information, the limitations of the Genetic Information Non-Discrimination Act, or GINA, and how genetics has changed traditional diagnostic medicine. So, in recognition of Rare Disease Day, let's get started. Hi, Susanna, and thank you so much for being on the show today.
Thank you for having me.
This episode is being released to coincide with Rare Disease Day. Can you tell us more about your experience and how it relates to rare disease?
Sure. So my mother died last year of a disease called CADASIL, which stands for cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. That's a mouthful. But CADASIL is an inherited genetic condition. It usually starts at midlife between age 30 and 50. And it's considered rare, or at least historically has been considered a rare disease. And CADASIL causes mood disorders, migraine, strokes, dementia, and eventually death. There's no known treatment or cure for the disease, and my risk of developing it is 50%. So, historically, the prevalence of CADASIL was understood to be between 1 and 4 people per 100,000. So, this would mean there's something like 3,000 to 12,000 people with CADASIL in the United States. The National Organization for Rare Disorders classifies a condition as rare if it affects fewer than 200,000 people in the United States. So, under the historical numbers, CADASIL would be considered a very rare disease. But over the last 5 years, there have been multiple large scale genomic studies about the prevalence of CADASIL in the general population. And they went looking for sort of known mutations that cause CADASIL in the general population through these genomic studies. And the data that's coming out of those studies has actually turned what we know about CADASIL on its head and has shown that the actual prevalence of CADASIL may be 100 times higher than previously thought, which would actually mean CADASIL is not a rare disease. So that's just sort of an interesting take on one disease.
So, talking about rare disease, you talked about the figures that NORD, the organization, kind of defines a rare disease. So is the thought that some of these rare diseases are not necessarily rare, we're just not finding the people that have them, or they're maybe being underdiagnosed or misdiagnosed?
Yeah, so I think if you look at a disease like CADASIL, so CADASIL presents with sort of common signs of dementia, potentially stroke, or even passing transient ischemic attacks. So it can look just like someone's having a normal stroke. There are no unique or distinguishing factors. So a disease like CADASIL may be wildly underdiagnosed. And I think what has been done historically is that CADASIL was identified in the 50s and the 70s in places like France and Sweden by one doctor following a family and seeing a pattern of strokes within one family. And then by the 90s, they had traced it to particular mutations on chromosome 19 in the Notch3 gene. And so it's a symptomatology. They look for particular symptoms and a pattern of symptoms within a family. And that's how it's been done historically. But now that we are able to do these large scale genomic studies within populations, we can look for those mutations in groups. And when we do that, we find that it's much more prevalent than we had thought. And that may be true of other rare diseases as well.
Mm-hmm.
So I think what that really says is when you widen the research lens and go beyond known molecular causes within particular families and you look much broader, what we understand as rare is through pattern recognition, but that's not the same thing as looking for molecular causes in the general population. And I think it kind of asks us to critically reconsider how we classify rare and what is the point of classifying diseases as rare. Does it serve us or not?
So, in thinking about the term rare disease or defining conditions as being rare disease, why do you think there is this label of rare disease, or what's the point of distinguishing rare diseases from not so rare diseases?
Yeah, so I think in the past we've classified things as rare as one way of both being able to get those diseases attention, and get families living with those diseases support. So there are organizations that focus on rare diseases and not a singular rare disease, but many of them together. So there's the North American Rare Disease Organization, NORD, and so it's a way of focusing attention and funding and research on rare diseases that might otherwise slip through the cracks. I think rare is also a reflection of how we've categorized disease. So, historically, again, backing up to the idea of symptomatology, we look for a pattern of symptoms and then decide we don't see this very often and therefore it's rare. But what is visible on the outside is not necessarily a reflection of what's happening biologically on the inside. And I say that because, so with CADASIL is a good example. There are 280 different mutations known now. There are probably more
Mhm.
in the future that cause CADASIL. And so, that the presentation can be somewhat different. The age of onset can be different, even within a single family. And so, if you're only looking at symptomatology, you may be missing how common something may be. If we take it even outside the idea of genetic disease, um, HIV/AIDS is an interesting example because HIV/AIDS was initially in the 80s a category, a list of symptoms that people were seeing, and that's how people were diagnosed as having AIDS. But the
Mhm.
list was developed based on gay men. And so, very early on, the people who were being diagnosed and recognized as having HIV/AIDS were gay men, and women who had HIV/AIDS could not qualify to have that diagnosis because they didn't have the same list of symptoms, even though they had the very same virus. And so I think symptomatology is a limited lens for viewing how common or how rare a disease is. And there are other ways of even thinking about disease. So, for example, CADASIL is caused by a single nucleotide polymorphism, one nucleotide change. Um,
Mhm.
but you could group all diseases that have single nucleotide polymorphisms as a category of disease. And they're all SMP diseases, which, if you were to look at it potentially from the idea of like gene therapy, if you were to say we're going to use gene therapy to address all of these diseases, and if we can find a way to cure one of them or treat one of them, it might be effective in other similar types of diseases. You would have this grouping of like one nucleotide change causing disease versus the symptomatologies are all over the map. What they actually cause in the body are wildly different. But I think the way we look at disease historically has been what can we see the body doing?
And probably because up until not too long ago, we didn't necessarily have the means or the technology, right, to look at what was causing the symptoms. So we started with what we could see, but really medicine's changing to that point where we're able to see the underlying mechanism. And so that brings about nuances and maybe a different way to think about how we categorize various conditions.
Yeah, absolutely. I agree with that.
One of the things I did want to ask about is I think with rare disease, I can see kind of what you mentioned where it is a way to bring attention to things that maybe are not as common. But one of the things I do worry about with the terminology rare disease is that it makes it sound like, oh, it's so uncommon, I don't need to worry about it, or I'm not affected, my family's not affected, why do I care? I've heard some people ask those questions when it comes to rare disease. What is something that, I guess we'll just keep using the terminology, but it's these rare diseases or really maybe not so rare diseases. What can they teach us about conditions that we hear about more commonly?
Yeah, I mean, CADASIL is a good example in this case, I think, because even though I've said rare, like CADASIL historically has been considered rare, the latest data suggests it's not actually rare. But what CADASIL actually is a form of vascular dementia. It causes breakdown in the blood cells of the brain. And vascular dementia, as a broader category, is not rare at all. And in
Hmm.
fact, among people over the age of 70, it's pretty common. And so I think when you look at disease in general, we can learn things about the biological mechanisms of what it's doing to the body, and those can often teach us something about other illnesses. And so there are several studies going on about CADASIL right now, about the etiology of how CADASIL develops. And those studies in the US are focused on this in part because of what it can teach us more broadly about dementia.
So we talked about how diagnosis of conditions, rare or common, are made on symptoms until now we've better understood underlying mechanisms or what's the cause of these symptoms. How do you think that change will impact either treatment or research for these rare diseases that maybe now we're finding out are not so rare?
Yeah, I think two things I want to say about this. So, one is I want to tell the story about how my mother actually got diagnosed with CADASIL, which is that she was having symptoms sort of, I would say, low grade dementia, memory loss, some issues with balance for 4 years. And her neurologist diagnosed her with multiple sclerosis. And she was treated for 4 years with multiple sclerosis. And every year she would go in to have an MRI, maybe it was even twice a year, to sort of see if there had been progression in what we thought was multiple sclerosis. And one time she went in for an MRI and they showed that she was having an active stroke. So they
Mm.
called her and asked her to come to the emergency room immediately. And she did, and they ended up treating her for what they thought was an active stroke. And she um, had a bad reaction to the blood pressure medication and she coded. So she had
Mm.
then a massive stroke. Um, and all of that is to say she was treated or she was diagnosed based on the symptoms she was presenting, and they were looking for a diagnosis that fit for the majority of the population. They weren't looking for the zebra case, and she's the zebra
Hmm.
case. And maybe it's not that extreme of a zebra, but she's the outlier. What ended up happening was my brother, who was a medical student at the time, went looking for alternate explanations. And he's the one that put CADASIL on the table. And he basically looked at what is every possible explanation, no matter how rare or how common, for these symptoms, and can we eliminate all of them? And it turned out, in fact, she had CADASIL.
Wow.
So I think that's just to say that now we have this technology where we can do genetic testing, or potentially even better, full genome sequencing. um, when we actually are able to do that, what we find is people end up with more accurate and better diagnoses much of the time. My mom is one example, but I think there are many other examples. One of the things that's been researched now is babies who are in the NICU. So, babies who are very sick when they're born and they end up in the NICU and they can't be diagnosed. When they take those babies who don't have a diagnosis but are in the NICU and do full genome sequencing on them, they find half of the babies have some sort of genetic mutation that doesn't rise to the level of a known genetic condition, but that's what's causing their symptoms. Which is just to say, when we go looking for the underlying biological mechanism, which may be a genetic mutation, we have a fundamentally different understanding of how disease is working. And now that we can do that faster and we can do it cheaper, many people are saying this should be sort of the starting place, is that we should do, when we don't have a better explanation or the treatment isn't working for babies or for someone who shows up with neurological symptoms, do the genome sequencing first. It's relatively low cost. It doesn't hurt the person, as many other treatments might have bad effects on the person, to understand what is actually happening in the body. And I think this also speaks to the potential for different forms of research and different treatment. And so, diseases that we may have understood to be rare or even extremely rare, a baby with a mutation that there are only two or three other children known in the world living with the same mutation, it might be the type of mutation this baby has is shared with other diseases, and effective treatment could be developed to address that type of mutation as opposed to that singular condition.
So again, thinking in terms of treating that biological, I always use the term mechanism, but that cause, because the cause, like you were talking about, like maybe it's just a single nucleotide is changed. There are multiple different diseases that look very different from the symptoms, but that biological underlying mechanism is the same, where it's this one nucleotide's been changed. So is that why people are looking at things like gene therapy as a treatment to maybe get as specific as they can to those underlying mechanisms?
Yeah, and we don't have, I would say, widely effective and certainly not affordable in use gene therapy now. And there will be different forms of gene therapy that are developed. So it's not a singular approach. Um, and I would say, even how that addresses mutations in the DNA, it's really about genetic medicine, right? As opposed to the biological mechanism. The biological mechanism of CADASIL is the breakdown of the blood barrier in the brain. But we're not necessarily, I think when you go beyond saying, I need a pharmaceutical approach to address the blood barrier in the brain, to saying, oh, I need to address this actual singular nucleotide polymorphism
Mhm.
in the Notch3 gene on chromosome 19, that's a
Gotcha.
completely different form of research, and it's a completely different form of therapy. And if we go that route, then you take all these different things that are considered rare, and they may be grouped in different buckets that are
Mhm.
not rare, and the therapeutic approaches are potentially shared.
Right. So it's kind of you're getting different layers to try to get to that one root cause, really, to try to even treat that root cause before it even becomes some type of physical manifestation, and not just treating the physical manifestation of that condition.
Yeah.
And so I think that then makes the case for this is why it's important to consider things like genetic testing or a genetic diagnosis. But we also know that genetic testing doesn't come without potential pitfalls for certain folks or certain populations. So I did want to ask kind of what does that look like for you? So knowing that you have a chance of having CADASIL, an inherited condition, but haven't yet developed signs or symptoms, haven't undergone testing, you're what we consider a previvor. So for those that don't know, a previvor means that somebody that has a chance to have an inherited condition, they just don't have signs or symptoms yet. What does it look like being a previvor in medical care? Or what does healthcare look like for people that may be at risk for these things, but we don't know for sure if they have them yet or not because they're not developing signs or symptoms?
Yeah, I think it's a great question. I think it's a reality that more and more people are going to live with as we're able to sort of identify genetic risks earlier and earlier. I think there's a really important distinction to make, and that is, what type of previvor are you? So, if you're a previvor of a condition that where there is effective prevention or treatment, I think healthcare looks very different. And so, hereditary cancer is a great example. There are others. But for people living at risk of hereditary cancer, there are a lot of things they can do. And if their risk is identified, if they actually have the appropriate genetic testing, they can get earlier screenings. They can have preventative treatments. Sometimes people opt for preventative surgeries. And if their genetic testing actually shows they have that particular gene, their insurance may be more likely to cover it. And so there are
Mhm.
advantages to clearly identifying and knowing your own risks if there is effective prevention or treatment. And where people come to that personally is up to them. But CADASIL is fundamentally different, as in there are no known prevention or treatments. And so, even if I were to go be tested and know I'm not at 50% risk, I'm at 100% risk, it doesn't actually change my healthcare. It doesn't change
Mhm.
anything I would do in the healthcare system, because there is nothing healthcare providers can do for me. So, the things I can do are lower my risk of stroke generally, which means not smoking, keeping my weight under control, exercising. But I don't need to be tested to do those things. I do those things anyway. So I think it there are different types of previvors. And I think what you can do with your risk is fundamentally different depending on what that risk is.
Yeah, and I think as somebody who worked in the cancer setting, that was one of the things was talking to patients and some of the patients said, "Well, I'd like to do the test because I feel like it helps me be proactive because we do have the studies in the case of like BRCA or the BRCA gene, where okay, if you have a mutation on that gene and you end up, let's say, having ovaries removed before a certain age, you can reduce your risk for breast cancer up to like 50%." And then there are some other types of things where it's risk reduction or early screening, so that if you do develop a cancer, we try to get it as early as we can in the more treatable form that we can. In your experience being a previvor, where there are no screenings, right? There's not necessarily a way that we would pick it up, or we pick up because of the signs and symptoms, but we still can't treat it. There's not a chemotherapy, for example, right? Or a surgery that we can do. How has that been discussing this with healthcare providers? Because I do find that healthcare providers tend to want to use their knowledge as power and use this to help, the patient, but this is an unknown area. So one, they don't necessarily know if someone like yourself has a genetic mutation or not. So they don't know, is the risk 100% or is it zero or close to zero? There's not necessarily a treatment that they can do. So how has that been in your area as a previvor, working with medical providers in that space?
Yeah, I'm going to be really honest. I think it's a deeply uncomfortable place for a lot of healthcare providers to sit in,
Hmm.
to try to talk to a person or a patient who has what most healthcare providers would consider a really significant risk of a disease that has really negative outcomes, and there's nothing they can do. And there's nothing I can do, particularly. I think it flies in the face of Western medicine in many ways. It flies in the face of the culture of medicine.
Hmm.
The culture of medicine really approaches information, and particularly genetic information, as inherently valuable. And if you know this information, then you can do something with it. And when they're met with an example where that isn't at least yet the case, it makes a lot of people really uncomfortable. I've sat in
Hmm.
multiple clinics where providers I really enjoyed and respected sort of said to me, "You haven't been tested." And they just seem to really be struggling to wrap their brain around why I wouldn't know this information. And for me, it's at this point become, it's almost like a psychological study, because I think there are the people who are on one side of that information, and they're living in this culture where information is valuable, and if you know something, you can do something, and if we know this information, you get a diagnosis, and if you have a diagnosis, we will eventually have a treatment or a cure. But for the people living on the other side, and by this I mean survivors living at risk of a disease without a treatment, people in that category largely choose the same thing, and many medical providers don't seem to engage with that. And so in this case, I'm talking about the Huntington's community, which is one of the most widely studied communities living with an autosomal dominant disease. And there have been many research studies that have shown something like 70 to 90% of people living at risk with Huntington's do not get tested. And this is the common choice. And yet, when you are that person entering the healthcare system, most healthcare providers don't engage with this is the common choice, and there's a reason people are making that choice. And so they just sort of, I think a lot of people think, well, you just can't engage with difficult information. And I think that's a real limited understanding of what that information means in people's lives.
So there's this thought in communities where doing the genetic testing is not necessarily power, and that can be uncomfortable, I think, for some healthcare providers, because I think many of them feel that knowledge is power, even if we can't necessarily do something about it right now. And you explore this right not to know, I think, in an article you wrote called Keeping Quiet About Genetic Risk. And it was in a publication called Health Affairs, and I'll put it in the show notes. Um, and and you talk about kind of going through this right not to know and not wanting to be tested, and that it did cause friction with some healthcare providers that could not wrap their heads around it, or understand that. And one of the concerns that you talk about, in not doing testing, was about, genetic discrimination. And so I was wondering if you could tell us a little bit more how that also influenced your decision to not have genetic testing.
Yeah, so I think my decision not to have genetic testing so far, I could change my mind at any point, but so far, is fundamentally an emotional one. I don't see a lot of value in knowing that information. And until I do see value in my life or my family in knowing the information, I choose not to know it. So I just want to say that at the outset, it's not driven by my fear of genetic discrimination. It's a fundamentally
Hmm.
emotional choice. But I think the fear of just genetic discrimination is very real. And in that essay, I talk about my experiences pursuing prenatal testing and applying for life insurance. And I ultimately also applied for long term care insurance. And the reality of the United States today is we do not have comprehensive legal protections for people who have genetic risks, significant genetic risks like CADASIL or Huntington's. And so, what we have right now is a law called GINA, which is the Genetic Information Non Discrimination Act. It's a federal law. It protects people from genetic discrimination in health insurance and employment, which means your employer cannot fire you, choose not to hire you, refuse a pay raise. You cannot have your premiums raised on your health insurance because of your genetic risks. But that law does not cover other forms of insurance, which includes life insurance, long term care
Hmm.
insurance, and disability insurance. And what that means in very practical terms is I can be denied or have my premium raised to a price that I cannot afford for life insurance, long term care insurance, or disability insurance because of my genetic risks. And I think this is not necessarily widely understood among medical providers generally, and even among some genetic counselors and people who provide genetic health care. I think when we're talking about the value of that information and sitting with healthcare providers who want you to know this genetic information, we also have to recognize there are very real risks to it. Some of them are emotional, but they're also financial.
Hmm.
Oh, I want to add to that, which is to say, so GINA is a federal law, which means it applies to everyone in the United States. There are additional, in some states, there are additional state protections. So there are states in which um, genetic information is protected from being considered in life, long term care, and disability insurance. I live in North Carolina right now, which is a state that does not offer any additional protections. So it very much depends on where you live, what types of protections you receive for any genetic testing that you have done.
I appreciate you sharing what influenced your decision not to go under genetic testing, and I think that's an important call out is that there are emotional factors, there's things that wouldn't change or would change, or things to consider that impact you and your family, and it's a personal choice, and it's okay that is it can be an emotional choice. I think that's the other thing is that some folks are like, and again, I'll don't mean to bag on healthcare providers being that I was one. But sometimes it is like, it's like, okay, well, let's look at it logically and take emotion out of it. And it's like, well, you can't, and nor should you separate that. And like you said, what's really going to change? What are we going to find out from this answer? But I also appreciate what you have been putting out there, talking about, writing about in terms of Gina and the fact that this is also a consideration and how that plays into people's decision. And again, I think both are areas where healthcare providers could do a better job in talking about the emotional aspects of selecting testing or not selecting testing, as well as things like real discrimination. Just because GINA and HIPAA are things that we have out there doesn't mean that discrimination isn't happening. And there are areas that are not protected at all, like you mentioned with life insurance or disability insurance.
Yeah, and I would just add to that I think the types of decisions people come to can be revisited. So, for
Hmm.
example, if effective prevention came out for CADASIL, I would very much revisit my decision to not be tested thus far, for example. If effective prevention and treatment came out in addition to protections for me being able to receive, not have my genetic information considered when I applied for insurance, all of those would influence my decisions to
Hmm.
be tested. So it's not an absolutist stance. I
Right.
think it's people are very much assessing it on a day to day basis or year to year basis of what is the purpose of this information in my life right now. Um,
Hmm. I like that too, and I think that that's a good thing to keep in mind is what is the purpose of this information for my patient at this point. Being as somebody who has had to work through areas where maybe you feel like you're not getting the support that you need from the medical community or from healthcare providers. Do you have advice for patients or families who feel like they're not being heard or listened to, or how can they find somebody that will hear or listen to them? How can they be their own advocate?
Yeah, I mean, I think one thing I would say is being your own advocate is tough. It's just tough, and you have to keep showing up and you have to keep doing it. I think going with your gut in terms of the level of trust and collaborativeness you feel with the provider is really important. I think keep making appointments and keep asking questions until you find a provider who you think is actually hearing you. One of the things we definitely found with CADASIL and in my family is that when my mother was diagnosed in 2008, it wasn't as well known as it is today. But the reality is, we had actually been seeing CADASIL for years. My grandfather died of
Mm.
CADASIL. My great grandmother died of CADASIL. And so we had a historic family knowledge of this disease, even though we didn't recognize specifically what the disease was or the acronym it was called by or that it was autosomal dominant. It was something familiar to us. And I think, particularly with hereditary disease, you have to sort of trust that intuition. And you also have to recognize that is a form of knowledge, even if it's not knowledge that appears in the diagnostic manual. And so I think it's hard to keep showing up with trained medical providers who have a certain gravitas and a certain training, but that your knowledge is also valuable. And you have to keep, I think, going through providers until you find someone that you can actually work with. One thing that I would say I now look for in healthcare providers and I really value is humility. And I think a provider who will show up and say, I don't know, is huge, because the reality is there are just a lot of things we as humans don't yet know. And I think it's okay for a healthcare provider to not know. And even if it's information that is known, they can go find the information. But if they will show up with patients and say, I don't know, let me go look. Or
Mhm.
I've looked, I've researched everything I can read, and we don't know the answer to your questions, but they're good questions. That's a person you can really talk to, in my opinion. And that's something I really value when I'm talking to healthcare providers. The
Mhm.
other piece I would say is there are a lot of organizations out there. So you can look for an organization that potentially focuses on a particular disease or condition if you have been diagnosed or your loved one has been diagnosed. You can also look to organizations that focus on a range of conditions. So I'm particularly thinking of genetic ones, but there's the Genetic Alliance. There's also, again, the National Alliance for Rare Disorders. So you can look for an umbrella organization that focuses on rare disease across the board. It's non disease specific, and that may be a good place to find people that you can collaborate with. The other piece I've had a lot of luck with is talking to academics. So,
Mm.
and they may or may not be clinicians, they may be academic researchers, but they're often very open to just sort of discussing their research or what they know, or even people they may be working with. It might open you up to research studies. And so I sort of will go and suss out who's working on this issue anywhere in the world and email them.
Well, and I think that's something that has been helpful with the internet and technology, is that there's ways to at least search or try to find people working in this space, even if it's something uncommon or only a few people are diagnosed with it. There generally is somebody somewhere out there that this is one of their areas of expertise or areas of research.
There are also, you might also be able to talk to this more. There are also databases now, particularly in the realm of genetic disease, tracking rare mutations. And so I had a friend whose daughter has a very rare form of epilepsy. I think there were 5 children in the world known to have the mutation she has that causes epilepsy. And so if you start asking, you can sort of get your particular test put in a database, which is what they did. And then they figured out, well, there are 4 more other kids with this particular mutation. So there are ways, I think, the internet and these databases are connecting us and sort of putting people in touch with each other.
And I think that's so important too, is the feeling of it's not just me. So, if you feel like you're not being heard by your medical team or your care team, it can be helpful to talk to somebody else who's going through something similar. And then you have support from at least someone else, even if you're not getting it from other areas. And so I think there is power and help for people just to know it's not just me. I'm not the only one encountering this.
Yeah, and I think if you really feel like you aren't being heard by your clinical team, you might not being heard by your clinical team. That might
Yeah.
just be true. That was very much true with our experience and why it took my mom 4 years to get a CADASIL diagnosis that didn't come through her clinical team.
Hmm.
And so I think it is okay to say out loud, I don't feel heard. And it is okay to seek second, third, fourth opinions if that's what you feel like you need.
Absolutely. Absolutely. And I do think sometimes too, I've encountered some generational differences too, where it's like you're not hurting your doctor's feelings. It doesn't matter. They're your doctor, they're there to treat you. If you aren't being heard, you aren't getting what you need, go see somebody else.
Yeah.
I'd like to segue to some things that you're doing now and that you're doing currently. You have a podcast called Genetic Frontiers, which is how I found you, and was listening to you. So tell us more about what you talk about on Genetic Frontiers and what inspired you to start the podcast.
Yeah. Thanks for asking. And thank you for listening, Kate. So, Genetic Frontiers is a podcast about the promise, power, and perils of genetic information. And it's an interview based podcast. And I chat with experts sort of in the field of genetics and genomics, although they are not all clinicians. I would say it's an interdisciplinary podcast. So I talk to historians, I talk to researchers, anthropologists. Sort of, I approach this idea of how genetic information is functioning in our lives from many different angles. And I started Genetic Frontiers because for a number of years I've been working on a book, which is sort of about my personal experience living with difficult genetic information and living at risk. And the book is a memoir, and it's also intertwined with a narrative nonfiction story about how genetic information is fundamentally changing the practice of medicine. But there were so many things that I wanted to talk about and I wanted to write about that didn't actually fit within the scope of the book. And so the podcast is a way for me to really talk to other experts about a whole range of topics. So I'll give you one example. In season one, we cover the topic of sperm banking and the sperm banking industry and how the introduction of genetic testing has fundamentally changed how we approach sperm banking. And one of the ideas within the sperm banking industry historically was that donors would remain anonymous. And then you intro DNA testing, either clinical or DTC, and sperm donors
Mhm.
can no longer be anonymous. And so it turns the entire industry on its head. And so I look at a number of different topics, just how DNA testing has changed the world we're living in. Right now, we're recording season 2 for Genetic Frontiers, which is going to look at how science, particularly genetics, is being weaponized and politicized in the United States today, and how ideologies grounded in eugenic thinking are driving American culture and particularly politics. So, if you want to learn more about the podcast, you can sign up for our newsletter at geneticfrontiers.org, or you can follow us on LinkedIn.
I think that is definitely a topic and a discussion that is needed in this day and age. I mean, I think it's something that those of us in certain genetics fields have discussed, but I don't know if it's something that's been more widely discussed in terms of, the history of eugenics and some of the things that are currently happening in the climate today. And we'll include a link in our show notes as well to the website, to the podcast. Thank you so much, Susanna, for being on the show today.
Thank you for having me, Kate.
For more information about this episode, visit allaccessdna.podbean.com, where you can also stream all episodes of the show. This link is also in the show notes for easy access. Any inquiries on the podcast can be sent to allaccessdna@gmail.com. Check out our Patreon at patreon.com/allaccessdna and consider donating to get bonus content, submit questions for our guests, and connect with other genetic curious individuals. Note that this podcast is for entertainment and education and is not intended to be a substitute for professional medical advice. Please consult your physician with any questions you may have regarding your health. Please rate and review the podcast on Apple, Spotify, or wherever you listen. This helps other people like you discover the show. All Access DNA is hosted, produced, and edited by Kate Wilson. The logo design is by Designs by NKJ. Thanks for listening and join us next time.